Thank you for joining Cancer Support Community Atlanta for Frankly Speaking About Prostate Cancer, facilitated by Dr. Ali with Northside Radiation Oncology Consultants and Dr. Zisholtz with Georgia Urology. If this is your first time participating in a Cancer Support Community Atlanta program, we invite you to visit our website and complete a new attendee form to stay connected to all future programs. Welcome everyone to Frankly Speaking About Prostate Cancer. I'm Katie Armsby, Program Outreach Director with Cancer Support Community Atlanta. If this is your first time participating in a Cancer Support Community Atlanta program, we invite you to visit our website, cscatlanta.org, to see all the free oncology support services offered virtually, which includes a monthly prostate cancer support group. As a reminder, everyone will remain muted for the duration of the program. Throughout the presentation, we invite you to enter questions into the program chat box, which the presenters will address at the end of the program during the Q&A. I want to welcome our two presenters today, Dr. Ahmed Ali with Northside Oncology Radiation Consultants and Dr. Barry Zisholtz with Georgia Urology. Presenting first will be Dr. Zisholtz. Dr. Zisholtz is a partner with Georgia Urology and practices at the Georgia Urology offices in Midtown and Riverdale. He's a fellow of the American College of Surgeons and a diplomat of the American Board of Urology. Dr. Zisholtz received his medical degree from New York Medical College and completed his chief residency at Beth Israel Medical Center in New York City. Dr. Zisholtz is a member of the American Urological Association. Presenting the second half of the program today will be Dr. Ahmed Ali. Dr. Ali practices with Northside Radiation Oncology Consultants at Northside Hospital Cancer Institute Radiation Oncology in Midtown. He completed his residency in radiation oncology at the University of Pennsylvania. Dr. Ali received additional training in the treatment of prostate cancer during the fellowship he was awarded through American Brachytherapy Society at the Seattle Prostate Institute. Dr. Ali is committed to staying up to date on emerging research and offering patients the newest treatments and most innovative technologies while minimizing their risk of treatment side effects. We'll go ahead and get started with the presentation, and Dr. Zisholtz, I'll pass it off to you.
Good afternoon, everybody, and thank you for joining us. As everybody knows, prostate cancer is a very important topic, especially as the aging population moves forward. And it is much more aggressive in African Americans. And prostate cancer, we see this on a regular basis in our office. And it is a subject that, frankly, a lot of men don't like to speak about, but is a very important subject. And with newer and newer innovations and newer surgical and radiation and therapeutic techniques, we can treat this disease, extend the life, and make people more comfortable. So what is the prostate gland? The prostate gland is a very small gland. Sometimes it gets larger as people get older, but it's really a gland that sits behind the pubic bone and connects, and has the urethra tube in the center of it and connects the bladder with the urethra. And it forms a lot of the secretions that a man has when they ejaculate to allow the sperm to survive in order to fertilize an egg. Obviously, when it gets bigger, it can put some pressure and constriction on the urethra, but that is called benign prostatic hyperplasia. That is not prostate cancer, but it could cause some symptoms of urination. Now, when the prostate becomes cancerous, then we have some issues that we have to deal with as that disease hopefully does not progress, but we have to treat the disorder, or sometimes we don't have to treat the disorder. Sometimes we can do observations. So I'm going to go through what prostate cancer is, and I hope I was able to differentiate that from benign enlargement of the prostate that can cause urinary symptoms, but is not cancerous. So what is prostate cancer? So any type of cancer, when cancer can form in any cell of the body, when the DNA changes of the cell, cancer can form. Cancer is when a cell divides somewhat haphazardly and has no control. And when it's localized, it's usually curable. When it spreads, it's much more difficult to cure. Again, enlargement of the prostate or prostatitis is not cancer. Prostate cancer is a specific disorder of the prostate gland that can be deadly, but many times can be cured, and sometimes does not even have to be treated. Okay, so the reason I started this talk, and the reason that I think that it's important, because we'd say that 1 in 7 men will be diagnosed, and with the aging population, a lot of people, that encompasses a lot of people, and I will, even though we're dividing this talk up, I will turn some of this over to Dr. Ali in the interim, because he could also comment that he sees so much prostate cancer as well as many other cancers. So I would like him to also comment, so we don't have to really separate it into 2 talks. With the African American population, not only is it more prevalent, and by the way, prostate cancer can be hereditary in about 15 to 20% of cases, but the African American population, more importantly, is that it could be more aggressive. And we don't know exactly why, but that's just the epidemiology of the disease. Again, here we talk about genetics. That's why it's important to, when you go to a urologist or to the doctor, to give your history, because really what we are is a genetic map. And unfortunately or fortunately, we are what our parents and our grandparents are. And it is the second leading cause of cancer and death in men after lung cancer. Any comment, Dr. Ali?
Yeah, interestingly, they've actually localized the gene locus for prostate cancer that gives African Americans a higher, higher rate, higher aggressiveness to Western Africa, and so that's something that we really has really come to light within the past 10 or 15 years, and so it's not just African Americans; it's many people of West African descent that have a higher incidence as well as a higher level of aggressiveness of the cancer.
Right. So again, it goes back to genes, and we just programmed genetic maps to a certain extent. But we do think that certain things that people can do to influence whether or not they're going to get cancer. Certainly with lung cancer, if you're a smoker, and with bladder cancer, if you're a smoker, if you're around certain chemicals, you have a higher chance of getting lung cancer or bladder cancer. And they think certain diets are more predisposed to prostate cancer, like a fatty diet, but nobody knows exactly what causes cancer. And I think a preponderance of the evidence show that it's likely related to your genetic map. And you can see up to 30,000 people will die in this country of prostate cancer. But you can also see that we diagnose up to 160, 170,000 cases. And a lot of people live with this for many, many years, even if it's not cured. And some people, again, we'll get to that later about treatment, some people don't get treated for it if it's very low stage and low grade. And look at the 5-year survival rate for all stages is very, very, very high, 99%. I'm going to bring Dr. Ali in this also because we see your early stages, and in terms of symptoms, some people will have symptoms, but the symptoms are very nonspecific because, as we said before, you could have an enlargement of prostate with some of the symptoms without it prostate cancer. So symptoms doesn't mean you have cancer, and unfortunately no symptoms, it doesn't mean you don't have cancer. Higher stages, you could have blood in the urine, but usually I would say 98% of the patients that I see with prostate cancer don't have blood in the urine, don't have really many symptoms. Screening test for prostate cancer, usually there's a digital rectal exam that may or may not feel a nodule, a PSA test, and they could have a biopsy.
Yeah, I think the dovetail on and for Barry's comments, most patients with curable prostate cancer in this era are not symptomatic. They don't have any symptoms. They wouldn't know they had it until they're diagnosed based upon an elevated PSA. That's the vast majority. Now, back before PSAs, patients presented with much more advanced disease, and they oftentimes had symptoms. Many of those patients weren't curable, but a lot of patients, unlike other cancers, they believe that if they're not symptomatic, they probably don't have cancer. They have a hard time, coming to terms with the fact that they have a cancer diagnosis. But it is in fact the case that you very much have prostate cancer that is curable, but not have any symptoms at all.
So how do we diagnose prostate cancer? When you examine the prostate, you only feel the backside of the prostate. There could be cancer in different parts of the prostate, but we're just feeling the backside. So that's why we get some of the blood tests like a PSA. But the only way to really be sure somebody has prostate cancer is to do a biopsy and have a tissue diagnosis. The biopsy is usually done in the office. It's usually with an ultrasound. Sometimes it's done with combining the ultrasound and an MRI. But the only way to make the diagnosis of prostate cancer is with tissue diagnosis. Nobody will treat the prostate, even if the PSA is very high. Nobody will really treat the prostate cancer without a tissue diagnosis. This is an interesting slide because the question is who should get the PSA, who should be evaluated. You know, as a urologist, when I see patients, I get a PSA. Not if they're 30, but if they've had a family history, if they're over 40, if they're African American, I'll get a baseline PSA. If they have any symptoms, I'll get a baseline PSA. That's because I'm a urologist, but most people won't get a PSA until they're about 50. But we see plenty of people with prostate cancer in their 40s, especially the African American population. So I think it's a worthwhile test, but there have been conflicting reports because if they're getting PSA tests and they're a little high and these people go through biopsies and many of them will be negative, then they say there's unnecessary treatment or unnecessary biopsies in people who maybe not have needed those biopsies, and they get all kinds of tests and they don't have prostate cancer. So I think in terms of screening, I think the cards are out. I don't think that, for us as urologists, we do it. I think that when I first started practice, we didn't have a PSA, and over 50% of the people that came to us in the 80s had already metastatic prostate cancer. Whereas today, once we started with the PSA, it was only 2%. So we're finding it much earlier. Now that a lot of the medical doctors are not doing PSAs, we're finding people with more advanced prostate cancer.
Mm-hmm. Absolutely.
You have any comment on that?
No, I fully agree.
Okay, so here's the possible benefits. If you get a normal PSA, you're fine. If again, normal is up to 4. But if you're 40 years old, you should have a PSA probably around 1. So it all depends on the size of the prostate and your age. Somebody who's 80 and has a PSA of 4.2, you probably won't biopsy it. So everybody's an individual. Everything has to be taken into consideration. When you see, it's just not robotics. It's you look at the patient. I saw a patient just earlier today. He was very frail. He was 68, had 2 strokes, 2 heart attacks. His PSA was maybe just under 10. But I don't know if he needs the biopsy because he has a gastrostomy too. He has so many other things going on. Let him get his strength back, and then we'll decide whether we need to do anything. So if somebody's very ill, you don't need to jump into this diagnosis because, as we saw, most of the time these are slow-growing cancers, and people do fine without treatment. And if they have other things that are going on, you may want to delay. Any comment on that?
No, I fully agree.
Here's screening the PSA, a digital rectal exam. And now they're starting to have some of the new research is doing urine tests to see if that shows certain proteins that could detect prostate cancer without having to have a digital rectal exam and a blood test. Those are in process. There's a couple companies working on that, and we'll see if they study the RNA in the urine to see whether or not there's prostate cancer. But again, the only way to make sure there's a diagnosis is with the biopsy. And different ways to do the biopsies. The most common way is on the right, the transrectal way. You put a probe in, you do a couple biopsies, and the most common is 12 biopsies. It takes about 4 or 5 minutes, and it's done with local anesthesia in the office. And there's minimal risks involved. You can get an infection, you can get some blood in the urine, but there's minimum risks, and usually very well tolerated. The other way to do it is to do it with the patient asleep like this, or with an MRI guided biopsy if there are any lesions that show up. On the left, if somebody doesn't have a rectum, you could do it transperineally through the perineum, or you could do it transperineally anyway, but most urologists are doing it transrectal. And if cancer is found, then we have to decide whether we treat it at all, whether we do radiation, surgery, cryosurgery, HIFU procedure, and that we can get into the treatment when Dr. Ali does his presentation. If it's very slow growing and it's only 1 out of 12 biopsies, sometimes we watch it. It depends on the age of the patient. It depends on what the patient wants. If it's intermediate risk, we usually recommend treatment. If it's high risk, we certainly recommend treatment. If it's advanced, we recommend treatment. But if it's metastatic, we can't cure it, but we can certainly do enough to keep that person with us in good health and in good quality of life for many, many years. I'm talking about 5 to 10 years at least. So just because somebody has stage 4 prostate cancer, that doesn't mean that it may mean that we can't cure it, but it doesn't mean that their life is over and they can have great quality for many, many years.
Yeah, Dr. Zisholtz made an excellent point earlier about prostate cancer and its management, in that it's highly tailored. Every patient is unique. Every patient's disease process is unique. There are certain risk categories and algorithms medically that we use to help guide us, to help give us a clue as to how aggressive their tumors are and what type of treatment would be best for them. But we really need to take the whole picture into consideration: the patient's performance status, their age, as well as a lot of the clues that go into their disease stratification. For low risk, intermediate risk, and high risk, those are all curable patients. They may have slightly different chances of cure, and there's a number of things that Dr. Zisholtz has already mentioned in terms of workup, like the PSA, digital rectal exam, and some other studies.
Like we said before, your custom treatment should be individualized based on your symptom and your quality of life and what you want to preserve. You see some of the older people who are not as much into sexual activity, but the younger ones are. So you have to identify a treatment plan that's right for that individual patient and that gives them the best chance to cure the disease. And so these are the options: surveillance, we said localized therapy with radiation, cryosurgery, HIFU, focal ultrasound, radical prostatectomy with an open or a robotic technique, hormonal therapy and chemotherapy, and immunotherapy is for more advanced disease. Again, I think I covered a lot of this. The active surveillance is for somebody who has very little cancer that's slow growing and that's very engaged to come in every 3 months for a PSA and an exam. That's called watchful waiting, but it's really not waiting. It's really not watchful waiting. It's really active surveillance. It's really, they have to be very engaged to come in regularly for their treatment. And then localized therapy. I'm going to turn this more over to Dr. Ali because I do a lot of cryosurgery. I do that for men who are old, not interested in preserving sexual activity, because cryosurgery, we cool the prostate down to minus 20 to 40 degrees Celsius, make an ice ball and destroy the cancer that way, but that will affect the nerves for the erections. So I usually either reserve that for after radiation or for somebody who wants one treatment outpatient and they're older and not interested in preserving sexual activity. HIFU, I have not done HIFU yet. Some people do the HIFU. It was recently approved, but you can get some more information online about focused ultrasound therapy. And we've been doing a lot of radiation, high density radiation with Dr. Ali, and I'm going to turn this over to him.
Dr. Zisholtz mentioned some of the focal therapies for curable prostate cancer. One therapy that was mentioned was active surveillance, following the cancer very closely to make sure these low-risk cancers don't progress. In which case they do, we could move on them with treatment. Prostatectomy is an option for all curable prostate cancers. It's a standard of care. And radiation is a standard of care option for all localized curable prostate cancers. And there's two different kinds of radiation. One is external beam radiation, in which we treat patients with highly targeted X-rays daily, 5 days a week for a number of weeks, where the radiation is actually being emitted and targeting the body from the outside in. And the other kind of radiation for curative treatment for prostate cancer is called brachytherapy. And that's internal radiation, where the radiation, there's radioactive sources that are placed directly within the prostate. And that radiation, we're able to escalate to very high doses and doesn't really go far beyond the prostate to cure the prostate cancer. And to further add another dimension is that there's two kinds of brachytherapy. One is called low dose rate brachytherapy, or LDR, and the other kind is called high dose rate brachytherapy, or HDR. Both of them are standards of care for prostate cure. The distinction is that the low dose rate brachytherapy, oftentimes referred to as prostate seed implantation, is comprised of seeds, radioactive seeds, that are permanently placed in the prostate. Oftentimes they're made of titanium and they're left there. Whereas the high dose rate brachytherapy is comprised of a similar approach. However, the main distinction is that the high dose rate brachytherapy, we place catheters in the prostate to allow very high doses of radiation to be administered in a short period of time, so short that the patients during the procedure get their treatment, and all of the radiation related or treatment related apparatus is removed. The patients are not radioactive permanently like they are with low dose rate brachytherapy. They are not radioactive and they leave without anything in their bodies. And there's a couple other nuanced differences with high dose rate versus low dose rate. High dose rate brachytherapy allows us to treat slightly larger glands or slightly smaller glands a little bit more effectively, and can allow us to treat certain areas of the prostate beyond the prostate, like the seminal vesicles, which are two small glands that sit right on top of the prostate, that may not be accessible with a low dose rate brachytherapy approach or a seed implantation approach. And yeah, Barry, please.
So so years ago, over 20 years, 25 years ago, we did a lot of seed implant, and some of the seeds stay forever. And sometimes people have problems and come back to us years after the seeds, and the seeds can erode into the urethra and they can need them to be scraped out. They can form little stones. With the HDR, nothing is left in. So I think that's an important thing. If everything is equal and the cure rate is the same and the long-term effects are equal, you don't have anything in there for forever. Instead of having 80 seeds in, you just had your treatment. I mean, what do you think about that?
I agree. Dr. Zisholtz and I, for a very long time together, treated patients with the LDR seed implantation approach. And, a little over a year ago, we adopted the HDR approach, and we've had a lot of success, and we really like it. The patients do well with it. All in all, it's been very satisfactory for us in terms of cancer cure rates, as well as in terms of the patients and how well they do with regards to side effects.
And the other thing is sometimes they have both. Sometimes they may have HDR seeds and combine that with number two, with external beam.
Correct.
And that's your judgment based,
Correct. Yeah, that's exactly right. So we talked about the internal radiation using high dose rate and low dose rate, and then the external radiation using the X-rays, the highly targeted X-rays. If you've got low risk prostate cancer, either one of those options along with surgery is appropriate. If you've got more advanced cancer, high risk or higher intermediate risk, which we call unfavorable intermediate risk prostate cancer, surgery is an option for those, surgery alone for those cases. But when it comes to radiation, we found that doing a combination of both the internal radiation, whether it be the seeds or the HDR approach, the high dose rate approach, combined with the external X-rays, the external beam radiation, works better and gives patients higher cure rates for a longer period of time. And that's called combination therapy. Oftentimes these patients also benefit with an adjunct treatment with hormonal treatment. And that's kind of a misnomer, hormonal treatment, in that it's actually withdrawing testosterone. And the whole purpose of that is that testosterone, or prostate cancer, is a hormonally mediated cancer, just like breast cancer is a hormonally mediated cancer in that it's mediated by estrogen. And when you withdraw the testosterone from it, you starve that cancer and weaken it. And doing that in conjunction with radiotherapy has been shown to have a synergistic effect in that it improves cure rates for some higher risk or higher or unfavorable intermediate risk cancers. And patients can be on the hormone therapy for as long as, or as short of a period of time as 6 months, and for as long of a period of time as 2 years in the curative setting in general. And oftentimes this is administered by way of pills and or an injection that you get every few months, every 3 months or so. Dr. Zisholtz, any input about that?
No, I think that for the higher risks, we try to keep them on for a year. But again, everything has a risk benefit, and when you're on hormones, they lose their desire to have relations, and the younger person is less likely to want to have the combination, who would rather not have the hormones. So everything has a risk-benefit ratio. The older people are more apt to stay on the hormones for at least a year.
Absolutely. So this is all, as Dr. Zisholtz was indicating, it's all a shared decision-making situation. We talk over the pluses, the minuses, the pros, the cons, the benefits, the risks of each of these modalities, whether it be radiation, surgery, or hormonal therapy, and empower the patients with the information they need to decide based on their priorities what they'd like to do. So moving on, for curative prostate cancer, which is localized, that remains within the prostate, there's no real role for chemotherapy or immunotherapy. The therapies are limited to the ones that we discussed, the surgery and the radiation options. But if the prostate cancer is advanced, meaning that it is spread to other parts of your body, like your bones or other organs, then there is certainly a role for systemic therapy that goes throughout your body, like chemotherapy and immunotherapy. And oftentimes that's something that is provided by the urologists and or the medical oncologists.
I agree, and the same with the clinical trials. Clinical trials reserved for tertiary centers that have specific IRBs that could do clinical trials for new therapies that are in the works.
Right. And a lot of those clinical trials are dedicated for advanced cancers, looking at different immunotherapies or chemotherapies.
And we talked about this throughout the talk, managing symptoms. These are the two dreaded complications of, especially for younger people, and that's why they develop some surgical techniques to preserve the nerves and to preserve the bladder neck sometimes, so that people don't have any leakage, or that they can maintain their sexual potency. As people get older and that is not as much important, they have more choices.
Right. So, the cure rates for a lot of these different stages are equal across the board between surgery and radiation. And so one is not better than the other. If one was, they both wouldn't be standards of care. So the decision that patients are grappling with doesn't come down to cure rates. That's kind of a non-issue. The issue oftentimes comes down to logistics, and it comes down to potential side effects. So as Dr. Zisholtz was mentioning, sometimes patients that are older, they're not sexually active, that may not be a consideration. So, certain therapies or approaches that have a higher rate of erectile dysfunction, such as external beam radiation alone or surgery, may not be, that may be favorable to those patients. But for younger patients that have a very active sexual life, and that's something that is a priority to them, they might opt for a surgery that may have, or an approach that may have a lower rate of sexual dysfunction, such as internal radiation, the prostate brachytherapy, whether it be low dose rate or the high dose rate approach. And the other big side effect is incontinence or leakage that may result in patients having to wear pads or diapers. And I'll let Dr. Zisholtz speak on that a little bit more.
So I think I want to just talk about the cure rate. If you look at the urological literature and some of the radiological or radiation therapy literature, one of the things, especially in the younger patients, that they think many of these studies show that there's a little bit of a higher cure rate with an operation taking the prostate out completely, and maybe it's 7 or 8%, but it's a small percentage, but it's a big operation. And the reason I say that is because one of the things that the patient has to know is, for the most part, once you choose radiation, most people are not going to get the surgery. So surgery is almost always out, because once you get high dose radiation to the prostate, to go in there and try to take out, if the cancer comes back, to do the surgery after radiation is very high morbidity. So a younger person needs to know that surgery is almost always off the table if they choose radiation at age 50. And that's a big decision, because that's a big modality that's sort of off the table with a very high risk. Now, having said that, I do a lot of cryosurgery. That I could do after failed radiation. But to take the prostate out after radiation is sort of not on the table for most, unless they're very skilled. But even then, the prostate is very small. It sits on the rectum, and there's a much higher incidence of having a colostomy or a bowel injury surgery after radiation. So that's an important point to let people know. The other thing is, for radiation, one of the other side effects could be a bowel, rectal bleeding or bowel discomfort. And so we developed, a company developed a little spacer. It's like a little gel that we put in many times before they have the radiation to push the rectum away, so that there's less chance of a rectal issue with the radiation. So that's a little bit of a nuanced complication that could occur with radiation that usually doesn't occur with any type of surgery. And so I just wanted to add that. In terms of incontinence, what I would recommend, if you're going to have the operation, go to somebody who's done a lot of them, whether it's open or robotic, and the incidence of incontinence is much lower. It's less than 7%, but you may need to wear a pad for a few months, but the incidence of incontinence is lower. So I would go to somebody who's very skilled and has done a lot of the surgeries.
And that one side effect of incontinence or urinary leakage requiring pads or diapers is not a side effect that occurs with radiotherapy. At least it's probably rare if it does happen. So, and that's with either external beam radiation or with the internal radiation, the brachytherapy. So, choosing your healthcare team, the point is that a lot of patients, when they get a cancer diagnosis, they feel like it's a 5-alarm fire. And a lot of cancers are very time sensitive. Most prostate cancers, nothing's going to change or impact you in a negative way if you wait a week or wait a month or even a few months. So it's really important to slow down and make sure that you gather all information that you need to make the right decision for you. And so it's a shared decision between you and your providers. It's very valuable for you to get all of the input of your urologist and your radiation oncologist, and that you deliberate and you can talk to colleagues, friends, other educational resources that may be of value, and you come to you're at peace with your decision before you move forward. So talking openly with your doctor, expressing what your priorities are in terms of both logistics, both preferences in terms of side effect profiles, what type of intervention you're open to, whether it be being totally non-invasive versus somewhat invasive versus surgically invasive. All of that is those are important factors when it comes down to distilling down to the decision, your final decision in terms of what the best treatment is for you.
I would agree with that. And it's not basically there's no cookie cutter for everybody. Everybody's an individual, and it's very helpful actually for me when a patient comes with their wife or their family to discuss it, because sometimes they don't say things that she might say, or she may say things that he doesn't want to say. So it's good to include them. It's no different than any other serious disease. I think that it's good to have family input as well.
Getting back to our earlier point, you have the time afforded to you by virtue of this cancer being a slower process to get a second opinion. And if that's something that you feel like would make you feel more secure in your decision to have two people saying the same thing, I always encourage that. And, of course, general health is important. A lot of my patients, I see them back. Dr. Zisholtz and I see these patients back. They don't have any evidence of having cancer anymore. Their PSAs are really low. They're doing great from a symptomatic perspective. So, their treatment's been successful, and that's why we do the work that we do, to get them from a place where they have this cancer diagnosis to a place where they're living their lives normally and in the rear view mirror. But if we do all of that and they're not taking care of themselves, and you see them developing heart attacks and other medical problems, and it's kind of all for naught. The whole purpose is for you to live a good life, a healthy life, and look at general health and general wellness. So it's really important that you look at the big picture. It all kind of goes hand in hand. In terms of the directives, to get plugged in with your urologist or your radiation oncologist, follow up every 3 months, or screening or PSAs. Really, if you stick with the program, you're going to be in good shape.
Right. And so in conclusion, get your PSA if you're at that age, if you have a family history, and your exam. And we're happy to answer any questions.
Thank you, Dr. Ali and Dr. Zisholtz, for that very informative presentation. Before we get to the Q&A, I do just want to highlight that Cancer Support Community Atlanta offers a monthly prostate support group and caregiver support group virtually. These are both led by licensed mental health professionals, and more information on connecting to these and other virtual support programs can be found at Cancer Support Community Atlanta's website at cscatlanta.org. All right, I think we'll go ahead and get started with the questions. This first one will be a general one for you, Dr. Ali. What is proton therapy?
So proton therapy is a form of external beam radiotherapy. We talked about the highly targeted X-rays that go through your body and really focus on your prostate. Well, instead of X-rays, they're using another type of beam. This is a proton beam, and there's just different properties of how the beam works. It's a newer technology that places are offering. With regards to prostate cancer, there's been a number of studies and trials looking at whether proton therapy is better than photon therapy, comparing those two head to head. And the data has been, kind of plus minus, but nothing that shows a clear benefit of one over the other.
Nothing dramatic.
Nothing dramatic. Some trials show some slight benefit to photon therapy over proton therapy, and vice versa. So therapy has really kind of capitalized on the promise that we thought it would, that it would help patients live longer or decrease side effects. That being said, it's a very valuable therapy in other settings. It has shown to have significant benefit over photon therapy in children for pediatric malignancies, spine tumors, certain brain tumors. But for prostate cancer, that really has not panned out.
Okay, thank you, Dr. Ali. Dr. Zisholtz, this next question would go to you. A participant shares, my doctor wants me to have a space oar implanted prior to radiation. What is this for, and are there possible side effects?
So I'm going to show you a little, I guess we're still on the screen. I'm going to show you, I don't know if you can zoom in on this, but if you look here, that blue between the prostate and the rectum, that's the spacor. So the spacor pushes the rectum away from the prostate, less risk of an injury from the radiation, less risk of bleeding and rectal injury from the radiation. The spacor is easily, as a matter of fact, I have two to put in this afternoon. It's pretty simple to put in. It's done on in the office, a little local anesthesia, and it's like a little gel. It gets injected there, and it dissolves over a period of 3 to 4 months. And so it could help protect the rectum. And there are some side effects from it. I haven't seen many. Sometimes you get a little discomfort, but for the most part, it's very, very well tolerated.
Okay, great. Thank you. And for patients, is there an expectation of how long that discomfort may last before it subsides?
Well, I've had one patient who has had pain. It lasted for about 8 days. I've done about 30 of them, and the rest did fine. So it's not that common.
Okay, thank you. And Dr. Ali, I'll toss this question to you. What is the difference between implanted seeds and a one-time delivery of high-dose radiation? And a follow-up to that, is one better than the other?
Yeah, so we touched on this very question earlier in our talk, but yeah, just to recapture some of the salient points, the implanted seeds are permanent. They stay in your body. You are radioactive while those are in for a long period of time. Oftentimes people say 8 months to a year. And the HDR is done in a very similar way in terms of what you have to undergo operationally. Catheters are placed within your prostate, and the difference is that the radiation is administered right after the procedure. It's delivered, and then everything is taken out. You are not radioactive when you walk out the door of the clinic that day. Nothing is left in your body. So that's the difference in terms of approach. In terms of cure rates, as far as we know, there's no difference. They're both equal. The side effects are generally the same. The time course of the side effects can be a little different. Typically with HDR, they're earlier, and then the side effects go away in a shorter period of time. With LDR, they can be a little bit more prolonged with the seed implantation. So there's really not that much of a difference, but for certain cases, larger prostates or small prostates or prostate cancers that are extending beyond the prostate, the HDR allows us to do things that are not necessarily possible with LDR in the same way with the seed implants.
Okay, thank you. And Dr. Zisholtz, I'll ask you this one. You mentioned genetics with family history. Are you utilizing any high-risk screening tools to screen patients for hereditary cancer and more frequent prostate exams or PSA testing?
So I think that point is very good. It's mostly based on history and following a PSA. The other thing that I failed to mention is that PSA in and of itself is not the end all. If I'm following somebody, let's say, who has a family history of prostate cancer, and the PSA, let's say, is 2, normal is up to 4 in the lab, and then next year is 2.8, and the year after is 3.3, it's still normal. But if the trajectory is going up and the PSA velocity is going up, and they have a family history, I would recommend a biopsy or an MRI if they don't want to get a biopsy right away. So the PSA direction is also important, as well as the PSA number. In terms of the family history, it's based on history. But if they do have prostate cancer in a family history, and they had a brother and a father, then I would make sure that they go for a BRCA test, because the BRCA gene is related to prostate cancer. And if somebody has a BRCA gene, they want to make first of all, there's other treatments. There's different treatments the oncologist can offer if it's advanced. And second of all, if there's a BRCA gene, then there's other family members, even their person's daughter, should be aware that they may have the BRCA gene.
Okay, thank you. And I think now would be an appropriate time to remind everyone that next week we'll be hosting a program, Hereditary Cancer Syndromes in Men. That conversation will be facilitated by Shritika Yola, certified genetic counselor with Northside Hospital Cancer Institute. And if you're unable to make that live program, you can find the recording on Cancer Support Community Atlanta's website as well. So this next question I think goes back to you, Dr. Zisholtz. What is a normal PSA range?
So that's, again, it depends on the age. The lab sheet will say PSA normal up to 4. But if somebody's 50 years old, it shouldn't be 3.8. It just shouldn't be. So you have to, again, that's the difference between the art of medicine and just looking at a number. So you have to take the patient totality and how big the prostate is and the patient's age, and look at the number and then make a decision whether you think that's abnormal. If you think it's a little high, you may just want to repeat it. And if it goes from 2 to 3.5, I mean, that's a jump. So you just have to really, but on the lab slip, it'll say PSA normal under 4.
Okay, thank you. And Dr. Ali, I think this question would go to you. My treatment for prostate cancer surgery has been delayed for 2 months due to COVID. Is this safe, and am I at risk because I haven't had treatment yet?
That's a great question, and one that's very poignant and applicable to the times. A lot of our patients were, I saw right before COVID, we had a plan in place, Dr. Zisholtz and I, to treat them with referred to surgery or with radiation. And we, as a group, because this is a new era and a new time, and we've never really come across anything like this in our clinical careers, reviewed the data and have had our individual specialties put out information and guidelines for us to tell us that, look, for prostate cancer, again, it's not lung cancer, it's not pancreatic cancer, it's usually very slow growing. And most prostate cancers, especially the low risks, the very low risks, the intermediate risks, higher unfavorable intermediate risks, we can hold off on without any compromise in terms of cure rates for a few months. Also to note, a lot of patients that are maybe higher risk, high risk patients, if we're worried about cancer progression over the course of 3 months or 6 months, we can place them on hormonal therapy. Again, that's withdrawing the testosterone, and by starving the cancer, that pretty much presses the pause button. And so patients can rest assured that their cancer will be kind of held in place and dormant until they feel safe to come in and start their treatment. This is a conversation that Dr. Zisholtz and I had on a daily basis as the COVID issue has evolved, and I'm sure he can weigh in as well.
I think that's exactly right. And so we had, a handful of patients that were scheduled for HDR, and we put them on hormones because we didn't know when we were going to restart. We didn't have a start date. So the ones who were nervous, or the ones who have more aggressive disease, or more, when you do the biopsy, they had more of if you do 12 biopsies, if they had a significant number of those 12 positive, we would offer them the hormones until because Northside, working with Northside, we said we're going to put this on hold to let the more aggressive cancers being treated, the pancreatic or the colorectal cancer. So we were able to do something to help the hospital system treat the ones that are more aggressive and put this on hold for, rest assured that at least we're treating it until we could do definitive therapy.
All right, thank you. I'm sure that's a question on a lot of people's minds at this point, so thank you for addressing that, Dr. Zisholtz and Dr. Ali. All right, and as we wrap up the Q&A, I want to remind everyone next week we'll be hosting a men's urology health seminar facilitated by Dr. Christy A. Bear with Georgia Urology. And if you're unable to watch the live version, you can find the recording at cscatlanta.org. I also invite everyone to visit Northside Hospital Cancer Institute's website, where you can find more information on prostate screenings and open clinical trials. So as we bring the program to a close, do either of you have any closing remarks you'd like to share?
No, I think, I just hope that this has been helpful to our audience. Thank you for your attendance. Thank you for your excellent questions.
Thanks for coming, and we hope to do this again.
Absolutely. And thank you both for sharing your time and expertise today. And thank you everyone for participating. We hope to see you soon. Take care. Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.